Hello everyone, I Sharada from Palamur University, Department of Pharmacology. Now I am going to discuss regarding the pharmacology of anti-asthmatic drugs. So before going to anti-asthmatic drugs, we need to know regarding the asthma. So what is asthma first? Asthma is a chronic inflammatory disease of airways which is characterized by inflammation, bronchospasm, and hyperreactivity. So these are the three main major factors which are responsible for the narrowing of airways in the asthmatic conditions. So asthma persons or the patients of asthma generally suffers with the symptoms like shortness of breath, difficulty in breathing, dry cough, night cough, wheezing, and chest pain. So wheezing is the very important and a common symptom, especially in the children, to determine the asthmatic attack. So there are a lot of risk factors or the causative factors for the asthma. In that, some of them are household chemicals, dust, genetic factors, fatty food, alcohol, viruses, pets, and pollution. Along with that, there are certain drugs like aspirin and occupational factors like working with the animal skin, chemicals, stone dust, and cement industries, etc. And upper respiratory tract infections, exercise, and emotional stress are also considered as causative factors or the risk factors for the asthma attack. So, asthma, how it will progress? How it will generally progressive in our body. That means whenever there is an initial contact with the allergen, so this allergen will interact with the B lymphocyte cells. So these B lymphocyte cells gets activated after the exposure to the allergen and converted into plasma cells. So these plasma cells start synthesizing the antibodies and release them after activation. So these released IgE antibodies, they occupy the surface of the mast cells. Now these mast cells are considered as sensitized mast cells. So these sensitized mast cells, whenever there is a subsequent contact with the allergen, so this time the allergen will directly interact with the IgE antibodies which are present on the surface of the mast cell, leads to the antigen antibody interaction on the mast cell surface. So this antigen antibody interaction causes mast cell degranulation at that site. So this degranulation generally causes the release of all the pro-inflammatory and inflammatory mediators at the site and activates the inflammatory response at that place. And inflammatory mediators, all these inflammatory mediators, they'll cause the edema, mucus hypersecretion, and smooth muscle contraction and increasing in the bronchial reactivity. All these generally they will cause the narrowing of the lumen of the airways and obstruction to the airflow. So here you can clearly observe that the normal airway cross section have a wide lumen and it can freely allows the air passage. And coming to the asthmatic patient airway wall, it is very thickened and the lumen is very narrowed, and that too it is filled with the hypersecretion of mucus. So this leads to the obstruction of airways, obstruction of airflow in this asthmatic condition. So there are many approaches to treat the asthma. So based on the pathogenesis, there are different approaches like preventing the asthmatic bronchospasm or reduce the amount of IgE bound to the mast cells or we can also prevent the mast cell degranulation, or we can also block the action of an inflammatory uh, products which are released from the mast cells, and also we can inhibit the effect of acetylcholine released from the vagal motor nerve, and also we can directly relax the airway smooth muscle. So generally asthma is a chronic disorder, so because of that reason we need to use long term doses. So in that, adrenoreceptor agonists are generally used as a maintenance dose, and inhaled corticosteroids are used as a controllers. Coming to the classification of anti-asthmatic drugs. So here we have different classes of drugs. That is, first one, bronchodilators. So in that, again based on the mechanism of action, we have three categories. That is beta 2 adrenergic receptor agonist, xanthines, anticholinergics. Next category, leukotriene inhibitors, then mast cell stabilizers, corticosteroids, and finally immunomodulators. So in this lecture, I'm going to discuss regarding the mainly mechanism of action of all these classes along with the examples of drugs. So the first category, that is bronchodilators, in that again the first one, beta 2 adrenergic receptor agonists. So the main mechanism of action of these drugs, they act on the beta 2 adrenergic receptors and they will cause increased levels of cyclic AMP. Increased levels of cyclic AMP. So these increased levels of cyclic AMP causes the phosphokinase E activation that leads to the downstream effects like relaxation of airway smooth muscle. Right? This is the main mechanism of action of these class of drugs. Along with this, they can also inhibit the release of bronchoconstricting mediators from the mast cell, and also they can inhibit the microvascular leakage. So in these ways, they can act as bronchodilator and also anti-asthmatic drugs. The main examples of this category, that is epinephrine, salbutamol, terbutaline, etc. And salmeterol, felmeterol are the newer generation of drugs in this category. The next category of drugs are methyl xanthines. So these are the drugs are least expensive and shows a better effectiveness. And the main mechanism of action of these drugs are they will inhibit the phosphodiesterase enzyme, which is responsible for the cyclic AMP degradation or cyclic AMP metabolism, right? So by inhibiting this phosphodiesterase enzyme, we can increase the cyclic AMP levels, and these increased cyclic AMP levels again activates the phosphokinases and leads to the relaxation of bronchial smooth muscles, causes the bronchodilation. The main examples of this category of drugs are theophylline and aminophylline, etc. Next category of drugs are anticholinergics in the bronchodilators. So they act by blocking the muscarinic receptors directly. They'll cause the relaxation of airway smooth muscles, and they are very better in the conditions like asthmatic bronchitis and COPD patients. Next, coming to the another category, that is leukotriene inhibitors. The main examples of this category are montelukast, zafirlukast, and xylutan. So here the xylutan, the main mechanism of action of xylutan is it inhibits the lipoxygenase enzyme, LOX, lipoxygenase enzyme, which is responsible for the synthesis of all the leukotrienes from the arachidonic acid. So by inhibiting this LOX enzyme, there is inhibition of synthesis of leukotrienes. In that way, it will act as a anti-asthmatic drug. And coming to the other two drugs, that is montelukast and zafirlukast, they act as a receptor antagonist. Receptor antagonist. They will block the actions of formed leukotrienes. And mast cell stabilizers. So the name itself indicates they will stabilize the mast cells and inhibits the degranulation process. How they will stabilize means they will block the calcium channels which are essential for the degradation process. Examples for this category of drugs are ketorolac, cromolyn and nidocromil. And corticosteroids. So these corticosteroids, uh, whenever they enter into the cytoplasm, so they are binded with the freely available corticosteroid receptors in the cytoplasm. So usually they are inactivated condition along with the heat shock protein complex, HSP complex. So whenever the drug is entered into the cytoplasm, so that will bind with the corticosteroid receptor. Corticosteroid receptor and HSP complex will be detached from the receptor and it gets activated. So these activated receptors undergo dimerization process and forms the corticosteroid receptor homodimer. So this homodimer enters into the nuclei and interact with the glucocorticoid corticosteroid receptor responsive genes. Okay, responsive genes. So whenever it interacts with these corticosteroid responsive genes, that leads to the either inhibition of transcription or inhibition of synthesis of proteins which forms the pro-inflammatory mediators and inflammatory mediators. So in this way they will act as a anti-asthmatic drugs by inhibiting the synthesis of pro-inflammatory and inflammatory mediators. And the last category of drugs are immunomodulators. So these are the new class of drugs in this category. They generally provide a long-term control of asthma. The main mechanism of action of these immunomodulators is they will alter the immune system by decreasing the IgE antibody response to the triggers. The one and only available drug in this category, that is Xolair, and it is also called as omalizumab. So this omalizumab is basically a monoclonal anti-IgE antibody, so that binds to the Fc region of IgE antibody and prevents the binding to the cell surface receptor, and also it can prevent the antibody antigen binding to the antibody. So in this way it acts as a anti-asthmatic drug. So there are several drugs which are under the development for the treatment of asthma in both existing classes and in the newer classes. So in the existing classes, long-acting beta-2 agonists and phosphodiesterase inhibitors and inhaled corticosteroids and leukotriene antagonist, 5-lipoxygenase inhibitors and immunomodulators are under the development. And in the new classes, cytokine inhibitors, especially interleukin 4 and 5 inhibitors and TNF inhibitors and cytokine synthesis inhibitors, etc., under the development in the newer classes. So this is regarding the information of pharmacology of anti-asthmatic drugs and pathogenesis of asthma. Thank you.